Welcome to the EAU podcast series on Andrology Chronicles, Messages for Men's Health. Join us as we delve into insightful discussions led by Dr. Roland Rees, a consultant urological surgeon and andrologist, alongside Dr. Sahdev, a consultant urologist and andrologist both at University of Southampton in the United Kingdom. In this second episode, Dr. Rees and Dr. Sahdev will explore complex Peyronie's dilemma and methods for effective management. Join us as we embark on this informative journey.
Well, hi there. This is the second Andrology podcast. My name's Roland Rees. I'm a urologist in University Hospital Southampton in the UK, and I'm here with my good colleague, Peyronie Sahdev, who is going to chat with me about challenging Peyronie's disease. Now, this is something that we all see. It's a very common disorder. So we're going to talk about complex Peyronie's dilemma. What are the best ways of treating? So first of all, there's a heck of a lot of options, if that's the right word, on oral and intralesional therapies. Now, how effective are they? Is there evidence that any of these things actually work?
Hi, Roland. Well, as you say, many of these treatments have been tried, both oral and intralesional therapies. So starting with the oral therapies, there's things like acetyl esters of carnitine, vitamin E, Petaba, of course, and even oral tamoxifen. In terms of intralesional treatments, there's been calcium channel blockers, intralesional steroids, hyaluronic acid, and Botox. Now, it's clear that, according to EAU, none of these actually have enough evidence behind them.
None of them. Wow. Yeah.
All of those are not recommended by the EAU guidelines, despite actually historically being used quite often. Yeah,
and they still. It's very difficult to look at patients, isn't it, and say actually there's nothing we can do at the moment. Yes. That's the challenge, isn't it? And that's why I think a lot of colleagues and probably myself included sometimes suggest something just so we seem to be doing something, but actually the evidence
isn't really
there.
Back it up.
Brilliant. And I mean, what effective conservative treatments are there?
So really, when it comes to conservative treatments, we're going to divide these patients up into patients in the acute phase and those in the chronic phase. In the acute phase, the main aim is to really relieve their pain and prevent them from progressing. Yeah, so that's the key aim. So in terms of relieving their pain, there is some evidence for NSAIDs helping with pain, as well as shockwave lithotripsy as well, believe it or not. Not something that's done very commonly in the UK, but there is some evidence that in the acute phase it can help, specifically with regards to pain.
We have to be specific there, don't we, and say that it doesn't
change the outcome and
change the curvature, but it's for pain. But
yeah, absolutely. If they have a degree of ED, you can give them PD5 inhibitors, obviously, and you can try traction therapy or vacuum devices. More commonly in the UK, we recommend vacuum devices.
And so that's for the acute phase, the inflammatory phase, if you like. What about? We see a lot of patients, they present later, don't they? They come along at 6 months, 9 months sometimes to the outpatients. They're in the chronic phase.
Yes.
Again, is there anything non-surgical that we can offer them?
Well, yes. You can also try the same treatments as for the acute phase, the inhibitors, not the NSAIDs at that stage. Hopefully they shouldn't be in pain. Traction or vacuum devices. But you can, previously we could have tried Collagenate.
Yeah, it's not available, is it?
Not really available in the whole of Europe, unfortunately, but there was quite strong evidence for this. And there was the IMPRESS 1 and 2 studies which showed 34% improved curvature versus placebo. Interestingly, the placebo group actually improved by 18%. Wow. So there was some improvement in that group as well. So you wonder whether that's a degree of disruption of the blood.
But it was statistically better than placebo, wasn't it? There was a scientifically proven treatment, but the problem was it was so expensive that it wasn't cost effective.
That's right, to distribute in Europe. It's still in the guidelines, however, so it's worth talking about briefly.
And what about other injectables? Is there any room for interferon or rapid?
Yeah, so interferon is actually recommended in the European guidelines. And there's been some evidence that this results in a 20% reduction in curvature in most men with Peyronie's disease. So actually quite good evidence there.
But side effects,
there are significant side effects. Coryzal symptoms especially.
Anything else?
Well, the evidence really supports those two intralesional treatments. Now, in terms of platelet-rich plasma.
Okay, PRP.
PRP.
Trendy.
Again, this is quite trendy. There are some studies that have shown benefit. However, the guidelines suggest that this should only be carried out in the context of a trial. So it shouldn't really be part of everyday practice.
Shouldn't be giving that out.
Yes. Yeah, absolutely.
Good. Okay. Well, I often say to patients, look, if the treatment that is the most likely to sort your curvature out is, of course, surgery by a long shot. So what surgical treatments are there, and how do you choose or how do you select the patients?
So the key thing is we have to be sure that the disease is stable. So this should be stable for a minimum of 3 months, ideally a bit longer. It's essential to assess the penile length, stretch penile length, and I do this in clinic. The degree of curvature, so ideally they should send you in a photograph in the erect face on the top and from the side, or you can give them an injection in clinic and take images that you can upload then for your records. It's essential to ask about erectile function. It's absolutely key.
Yeah.
The data for surgical management is really based on retrospective single-center studies to non-randomized sort of cohorts, or indeed expert opinion. So, all of this, the evidence for this isn't particularly strong necessarily. However, there are broadly 2 types of surgical procedure, chronicles shortening procedures. So this would encompass plication, Nesbitt's procedure, the 16-dot technique, Yakia. So these are appropriate for patients that have got congenital curvature, Peyronie's disease with adequate penile length and rigidity, so good erectile function, and those with a less than 60-degree curvature without any complex deformities such as hourglass deformity or hinge deformity.
So these are essentially the simple cases that we would hope that most urologists should be able to identify. And I think that's the key, really, is identifying the straightforward cases, because the difficult ones, which we'll talk about later on, are a difficult bunch of people.
Absolutely, completely different kettle of fish.
And they have really, I think they should be dealt with by specialized andrologists. But the standard Nesbitt type corporoplasty, it's a bit unfortunate that they call them penile shortening procedures, but they are. I suppose that what I say to patients actually is that the disease has shortened the penis. So the disease has shortened one side of your penis, and we are now going to make the other side of your penis the same length as that one. So it's then you kind of blame the disease, really, and I think quite justifiably for the shortening, and not blaming the operation so much, because it's a very good procedure in my view. But bringing us on to that, what are the risks of corporoplasty or tunical shortening surgery?
Yes, so as you already discussed, penile shortening is the key one.
Yeah.
Erectile dysfunction is a risk around the 5% mark.
Mm-hmm.
They can get a recurrence of the curvature. They may be able to feel the stitches. That's not actually in our local consent form in the UK. However, I always mention it.
Yeah.
The need for a circumcision is absolutely key. I tend to circumcise all of these men. I don't know about you. There's some...
Well, I mean, it's interesting, isn't it? I mean, I know there's some evidence that in those men who've got a loose foreskin and who've having surgery for the first time, that you can get away with not circumcising. So degloving procedure, putting the foreskin back where it was, and consenting them for very small risk that they may develop phimosis. So in the guys, and then unfortunately there's an increasing number of them who do not want a circumcision.
Yes. Yeah.
I agree totally that the recommended best way of healing and getting over this is with a circumcising incision. But if they insist, then I say fine. So long as you agree that there may be a need for circumcision later on.
At a later stage.
That's fine. And I think back to your point about palpable sutures, then, if we can use slowly dissolving sutures, particularly PDS, then you can basically tell them that eventually these sutures will disappear.
Yes.
So I would not recommend, personally anyway, nylon or non-absorbing sutures. Otherwise, you'll find yourself going back, one day, 6 months later, to take these stitches out for some of these men who are irritated by the residual curvatures. But overall, I think it's a really good operation. Having done hundreds of these, then the reoperation rate is very small indeed.
Yes.
So that's the simple stuff. What about when we want to lengthen the diseased side, the shortened side? How is that done, and who should we be doing that for?
Yeah, so that should be carried out for men that have got significant penile shortening as a result of their disease. and the classic figure is a cutoff is 60 degrees.
Yeah.
There's actually no studies that confirm this.
Yeah.
That have looked into this. It's one of those slightly arbitrary numbers.
It is, isn't it?
It is.
Slightly plucked out of the air.
Yes, exactly,
Yeah.
exactly. However, it acts as a kind of guide, really. So patients who've got complex deformity, certainly you don't want to be doing a Nesbit or a penile shortening procedure in them. They've got an hourglass or a hinge deformity. And also, these men have to have no underlying ED, ideally very strong erections, because the risk of erectile dysfunction, as we're going to come on to, is very high.
Yeah, I mean, exactly that. And I think I say to my patients who are considering this that the problem rate or the complication rate is high, isn't it? It's 20-30% of patients will be unhappy from one point of view, whether that's a recurrent bend or whether it's worsening quality of erections. But I totally agree. You can't plicate or do a Nesbit on someone who has a narrowing, a tight narrowing, because you'll make that area even narrower.
Yeah.
So you've got to think of ways of expanding the circumference of the penis at that point.
Absolutely.
So, okay then. So we're going to lengthen the tunica. What are the pros and cons here?
So the idea is that you minimize penile shortening. I would never promise them they'll get no shortening, because as we know in practice, you often have to do adjunctive maneuvers such as additional plication.
Just one stitch or something.
Yes, exactly, to actually correct the curvature as best you can. You've got to tell them about the risk of ED, which actually in the European literature is up to 50%.
Wow, okay.
Slightly higher, I think, than what we see in clinical practice personally. But the other thing is clearly numbness. Having to usually mobilize the neurovascular bundle does give a risk of about 20% of numbness.
Yeah. I mean, I think we do suffer a bit as andrologists in that our operations are often blamed for things. So just like the Nesbit procedure is blamed for shortening, whereas actually it's the Peyronie's that's really changed the character of the penis. In this particular operation, the grafting procedure is blamed for erectile dysfunction. But, we know that some of these, if these men were not having the grafting procedure, a lot of them would get ED anyway, because they've got severe Peyronie's. They're by definition of the fact they've got a very nasty bend or a waist or a severe scarring, they're going to get ED. So not all of this ED is, I think, is to be blamed on the operation. But clearly some of it will be.
Yes, yeah.
Okay. What sort of graft are you going to use then? Are you going to use the good old saphenous vein, or are you going to have something a bit more up to date?
Well, there are all kinds of grafts. There's the autografts, as you say, the saphenous vein, more traditional approach, I'd say. There's the allografts, xenografts, synthetic grafts. Most people in practice in the UK, as far as I'm aware, use xenografts.
Yeah.
So I use the St. Jude's bovine paracardium. But there's very little evidence or studies comparing the different grafts. So really, it's a matter of really whatever you find the most effective in your practice. That seems to be the general.
It's interesting, isn't it? Because there's no, as you say, there's no head-to-head study with these materials, but there are loads of studies in the literature all quoting 80-90% success, inverted commas.
Yes.
But ultimately, I guess it boils down to what is available, what you feel comfortable with, what is cost effective, and I think what causes the lowest level of tissue reaction or fibrosis. That's what you need. You don't want to be stirring up more inflammatory reaction in the penis. Cool. Well, I think we're nearly there. Obviously, the final option for severe Peyronie's, which is increasingly indicated, I think, is the penile prosthesis. So when would you use an implant for a man with Peyronie's?
Well, I would use an implant in man with Peyronie's really when they've tried everything else in terms of medical treatment and intracorporeal injections. Also in those men that have got complex deformities, especially if they've got distal flaccidity, doing a procedure or a loop procedure in these men is likely to result in not very good satisfaction, I would say. You still need to advise them about being realistic, especially about penile length, because as we've already discussed. And the goal in this instance is a functionally straight penis, which is satisfactory for penetration. So the evidence, again, in this field is even more scant.
Yeah, absolutely.
But,
case series.
Yeah, mostly case series, which are retrospective with small numbers of patients, limited follow-up.
Yeah, I mean, I think this is really difficult territory, isn't it? Once you're talking about putting an implant in a man with Peyronie's, you're dealing with somebody who has got poor erectile quality, poor blood supply, quite a bit of penile scarring, shortening, and all the psychological problems that goes with that. They're a different breed of patient to those maybe who've had, I don't know, vascular problems or a radical prostatectomy in whom you're putting an implant into. These guys are tortured by penile scarring, curvature, difficulties, changes in appearance, and all the psychological sequelae of that. So they're a difficult patient group. I think that has to be borne in mind from the very beginning. And I think, managing expectations here is key, because they are, particularly around the penile length thing.
Yes.
This implant, the trouble with Peyronie's is it's a fibrotic condition. Fibrosis doesn't stretch, and your penis will not stretch or become as long as it used to. And they've got to tell them that from the beginning. This is a new normal. The penis is shorter, but we will try and make it as useful as possible. And on top of that, the operation is difficult.
Yes,
you've got to try and dilate in scarred corpora. The shape of the penis, even with the implant in, will be not normal. So very difficult area to try and get happy patients.
Yes, absolutely. Yeah, difficult.
So what about finally, really, what if you put your implant in and blimey, there's still a severe bend? What are we going to do to try and get the penis straight and functionally useful?
Yeah, so you've got a couple of different options, really. I think the literature says that if there's a curvature after you put the prosthesis in of less than 30 degrees, that you can leave it well alone and actually
straighten itself.
It will straighten itself, essentially. If you've got a curvature more than 30 degrees, you can then carry out what's called modelling, whereby the penis is inflated to maximal rigidity.
So that's step 2.
That's right, that's step 2. So that's your first adjunct, really. You put shods on the tubing from the cylinders to the pump, and then you bend the penis contralateral to the curvature and hold it for 90 seconds or until your hand is
basically stretching in the opposite direction.
Yes, exactly. Okay. Exactly. And you can carry that out a couple of times, and that's got a good success rate of around 86%.
Okay.
There is a risk of urethral perforation with it, about 3%. So it's been a bit of a modified technique whereby more pressure is applied to the glands to try and reduce the risk of that occurring.
Okay. Yeah, fair enough. So, and if that doesn't do it, what else can you do?
Well, you can actually do something called home modelling. It's been discussed in the literature. So Oncada talks about that. Essentially 4 weeks after the surgery, the device is inflated maximally, and then the patient essentially moulds it themselves. So bends it for 30 seconds in the opposite direction to the curvature several times a day.
Right.
And that had a good result in patients with a curvature less than 45 degrees after modelling.
Right.
And 95% at 6 months had a curvature less than 10 degrees.
Wow. So that's quite a good result, really. So basically getting the, not to panic too much at the end of the operation, because, there'll be improvements as the tissue expansion takes place from the implant.
Absolutely. After that, you can do, there's the scratch techniques has been described by Peyronie.
Oh,
which is kind of an adjunct to the modelling, really. So the idea is to try and optimize the efficacy of modelling by putting a hook-bladed knife in. It's usually done by the intrapubic approach.
Sounds quite sporting, doesn't it? But you're basically putting a blade down into the corpora. So this is an operative intervention.
That's right. Via a nasal speculum, and you essentially incise the fibrous tissue.
Right. So really for experienced surgeons.
Experienced surgeons, absolutely.
I mean, I suppose between all of those things, then we're going to get most penises relatively straight. I mean, is there space, or is there a place for putting stitches on the other side, doing some sort of Nesbit in combination with an implant? I mean, it must be quite dangerous in terms of, you don't want to be putting stitches into or puncturing the implant. That would be the disaster, wouldn't it?
Yeah, no, absolutely. So plication has been described. Those stitches are put in before the implant's placed.
Very good.
To try and avoid that very complication. Essentially, you can either deglove the penis or just incise straight over the area of maximal curvature after artificial erection.
Yeah. Okay.
And then you can always take the sutures out if modelling is effective. So it's quite certainly.
But I imagine that's not very popular because it's the penis is shortened.
That's right.
Probably, and now it's shortening it even more.
That's right. So the common concern is shortening, and all of the studies, although low in sort of numbers, have actually shown, all of them essentially have shown that they're the main thing people worry about shortening.
Finally, the most sort of adventurous of all maybe is the combination of putting an implant in and then carrying some sort of grafting procedure out.
Yeah.
What's the evidence? Is there evidence that is a good thing?
Well, this gets into more complex territory. So you can do briefly, just to sort of describe the landscape of the other options: plaque incision or excision and grafting.
Okay.
You essentially doing a combination loop procedure and an implant. You can also do a modified version of that using Tacosil instead of an actual graft.
So that's a fleece.
That's the fleece, a collagen fleece, which saves a bit of time because you don't need to suture it in. You can just place it over the defect. Yeah. Other more adventurous approaches are things like the sliding technique.
Yeah, the sliding technique is, I've never tried this actually, but it's where the corpora are incised on both sides and then essentially elongated. It's difficult to describe in a podcast, isn't it? But the pictures will tell you. But I mean, my feeling about all of this is that here you have a man who has inherently has vascular disease, because we all know that severe Peyronie's, 2/3 of them, if not more, have vascular risk factors.
Yes.
You're then mobilizing the neurovascular bundle and dissecting the penis out.
And sometimes the urethra as well.
And the urethra as well. Disassembly. Then you're putting an implant in and leaving that sort of semi-inflated. So I worry about this technique a little bit, because there's so many things that can potentially contribute to reduced blood supply to the tip of the penis, that I think, there's some studies, aren't there, showing quite high complication rates with these problems.
That's right. The thing that everyone is concerned about is about glands necrosis, really. And that has been described absolutely in the literature, which is a complete disaster.
Well, that's exactly.
There have been some modified techniques, such as the multiple slit technique, whereby the prosthesis is inserted, the penis is degloved, the neurovascular bundles mobilized, and then the cylinders are inflated, and then multiple incisions are made to correct for the curvature. So the idea is that there's a lower risk of ballooning of the cylinder.
Okay, good. Well, I think, that's probably would draw it to an end, really. I think, thankfully, most patients will get straight with just the dilatation and the implant and maybe some molding. I think that's majority of people.
Yeah.
Not many need these more adjunctive procedures, but it's good to know. It's great to tell patients, I think, with severe Peyronie's disease who are very miserable when they come into your clinic for the first time and say, well, actually, there are things we can do. We can restore the majority of these men's sexual functioning one way or the other.
Yes.
Even if it does mean an implant. And it's about managing their expectations and bringing down their expectations, quite frankly, that you can't put this back to normal.
Yeah.
You cannot turn their penis back to what it was like, in the past. But we can hopefully restore sexual functioning.
Absolutely. It's a case of under-promising and over-delivering.
Yeah, absolutely. Nicely summarized. Difficult area. Well, thank you for listening. And hopefully that was an useful run through challenging Peyronie's disease. Thank you.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.